Thank you to the BMJ for recognising our innovation in QI by shortlisting us. Our team offers joint antenatal diabetes care for women with diabetes in pregnancy. Gestational diabetes increases the risk of adverse maternal and fetal outcomes, including difficult births and pregnancy losses. It is a growing public health concern that affects up to 20% of pregnancies across the world. We are a District General Hospital located in the city of Derry, Londonderry, in the northwest corner of Northern Ireland. Here the incidence of gestational diabetes ranges between 8 and 14%. We serve a population of 300,000 people across 5,000 square kilometres. Our outcomes showed us that our service was providing safe care, but the demand was steadily increasing. As a team, we were continually stretched with increasing incidence of gestational diabetes in our population.
Between 2013 and 2018, the diabetes team had already made some changes to the traditional model of care. We moved the consultant physician, specialist dietitian, diabetes nurse, as well as the patient into the same room during consultations. This reduced duplication, ensured consistent messaging, and it also facilitated collaborative care planning in partnership with the woman. We saw the benefits of these changes, with low insulin usage and more controlled maternal weight gain. However, just like the rest of the UK, we saw increased incidence of gestational diabetes and a high proportion of ladies with a BMI over 40 at booking.
We knew we had to change our systems, but we didn't want to compromise on the safety for mothers and babies under our care. As we embarked on the changes and improvement described here, we monitored outcomes such as difficult births, pregnancy complications, and rare but catastrophic outcomes such as pregnancy loss as a balanced measure.
In June 2018, we began addressing these challenges using the flow coaching methodology. This incorporates pathway expertise, improvement science, and team coaching. We started meeting every week in our Gestational Diabetes Big Room with our flow coach. It gave us an opportunity to work as a truly multidisciplinary antenatal diabetes team, involving all staff who directly or indirectly participated in the care of ladies with gestational diabetes, from conception right through to postnatal care.
We all had our own ideas of what the problems were and what the solution should be. Some of us have worked in the health service long enough and we've seen new fads come and go, and we were somewhat sceptical of this new process. But through our big room, we got to know each other much better. We understood what each of our roles were, and we learnt new skills as a team.
The steer for where we focused our attention came from the ladies who often joined us in the big room.
Hi, my name's Joanne, and I'm mummy to 3 young children aged 4.5, 2.5 and 7 months, and I've had gestational diabetes in all 3 of my pregnancies. When I returned to work after the birth of my second child, I was invited to participate in the Big Room project, and I jumped at the chance by looking at user experiences and talking about what worked and what didn't work for clients at the clinic, and looking at where the problems were in the system. They were able to design it, completely redesign it from the ground up.
We started by listening to what mattered to the women who experienced our service, what added value to them and their expectations, spending nearly the first 3 months deepening our understanding of both the system and the care experience that it offered.
There were times the task felt overwhelming and we were at risk of going adrift. But one day at our big room, someone reminded us that calm seas don't make good sailors. We found that by keeping the patient experiences and their stories at the centre of our big room, it gave us a steer and kept us on course.
Together, it gave us the opportunity to think outside the box and to build our vision of what an ideal antenatal diabetes service should look like. We decided to focus on 3 core areas affecting the experience of women. These themes were recurrent in the feedback that the women shared with us.
We first set out to reduce waiting time at clinic by 50% from the baseline average of 66 minutes. Using Gantt charts and process mapping, we understood the constraints. 5 PDSA cycles later, we reduced waiting time to an average of 23 minutes. Changes to appointment scheduling meant that by January 2019, our clinics were flowing much better. A year later, this improvement remains sustained.
Alongside women using our service, our diabetes colleagues, dietitians and midwives, we set out to decrease the number of blood glucose checks by 30% from the baseline average of 56 per week. Finger prick glucose checks are painful and intrusive to women who are already experiencing high levels of pain and discomfort during labour. Through our tests of change, we were able to reduce the checks by 26% without compromising on safety of care.
Women raised concerns about long waiting times and multiple visits. The visits were intrusive to their work and family life, with many women arranging childcare to attend 1 to 2 weekly clinic appointments.
To address these challenges and make our service more accessible, in early 2019 we developed a prototype video clinic that met information governance principles. The tests of change were full of humble learning. Along with the feedback from the ladies, we refined the process and built on our early experience.
By looking in detail at user experiences and where the problems were in the system, they were able to completely redesign it, introducing things like the glucose app and virtual clinics. Then last winter in my third pregnancy, I had the experience of this firsthand, and it's just incredible to think how something that started with a fun exercise like loving nuts made such an impact on the quality of care that I received.
When it was time to expand the video clinics, we needed a process to introduce the new clinic model to potential users. Here's a snippet of an animated video that staff and service users co-designed together. Using app-based video technology and smart glucose monitoring devices, we were able to offer virtual consults, the same safe care with no travel, less waiting and fewer hospital visits. As a result, there was a 31% reduction in diabetes visits. Diagnosis in early pregnancy resulted in a higher than average visit per pregnancy episode, reflecting a desirable variation. In obstetrics, there was a 23% reduction in visits. By June 2020, we'd hosted 658 video consults. To the busy mums who attend our clinic, the time and money saved by video clinic adds value. The environmental impact isn't small either. Fewer appointments means a cost-effective change for our trust too. The virtual consults have eased the pressure at clinic, improving the experience for both patients and staff. We have now scaled the service to include women with pre-gestational diabetes.
The virtual clinics have been life-changing for me as a patient with a new diagnosis of type 1 diabetes alongside a pregnancy. The virtual clinics have allowed me to access support, access advice and guidance regularly, frequently, without much hassle. It has really helped me in a time of change and transition, I suppose, with a new diagnosis, learning to live with that and having the right support around me. It's made it accessible for family life and work life, and I've even attended a virtual clinic on holiday.
The Gestational Diabetes Big Room has had a really significant impact in our organisation, not just on the care of a very vulnerable and growing group of women and their unborn babies, but also on us as a trust. As part of the Big Room, the team worked to test the feasibility and to develop and standardise their approach to video consultation. And this has proved the seed of an initiative for us right across the organisation. This has enabled us to bring video consultation in a standardised way to other services, to other service users and patients. And in my role as part of the HSCQI Alliance for Northern Ireland, I've been in a position to share that learning with trusts and organisations right across the region. So from the Diabetes Big Room and its initial intent on improving outcomes for women, we have in fact discovered an initiative which standardises our practice across the region, offers us an opportunity to be, as it were, somewhat pandemic-proof.
The digital innovation is visible. The cultural innovation is tangible to us in the human change we experienced as a team, moving from what we saw as a fixed model to a more collaborative team, including people with lived experience and staff with a shared purpose. A fresh outlook on what is possible together. 18 months of Big Rooms later, here's how we feel about it.
A new way to do things.
Thinking outside the box. Efficiency. A new culture for patients and staff. Service improvement. Teamwork. User empowerment. Communication. Collaboration. Women-centred care. The best team to work with.